Good morning, everyone. Thanks for joining MOT Rounds this week. It's really a pleasure to introduce colleague and friend, Peter Reese. Peter is an associate professor in the Department of Medicine, as well as Epidemiology, Biostatistics, Medical Ethics, and Health Policy at the University of Pennsylvania School of Medicine. A very, very accomplished academic, researcher, teacher. He's published over 170 peer-reviewed articles and has really been impactful in a number of areas, but particularly in the areas of kidney disease, kidney function-related research, and of course, kidney transplantation and living donation. And he's held a number of leadership roles as well. And so I'm really, really pleased that he's joined us today to speak about a very topical issue that's germane to our current practice as well, not just in kidney transplantation, but in organ transplantation in general. And that's really how to optimize the use of deceased donor organs. And in particular, he has an interesting perspective here because he spent some time in France actually on a sabbatical recently and has used data from both sort of local as well as international sources to really glean some new insights on how we can do this better. So without further ado, thank you, Peter, for joining us. We look forward to your presentation.
Thank you. Well, it's a pleasure to be here. Full disclosure, I will be focusing on kidneys, but I'll try wherever possible to, make the insights generalizable to all the other organ systems and the valuable work that you do at UHN. Disclosures not relevant, but I run some hepatitis C trials and have some grants from drug companies to support those. So as I'm sure you'll agree, the lack of transplantable organs is a major public health problem. Yet in the US, we discard 15 to 20% of donated kidneys. And what has gone on with me over the past 3 years is a recognition that there's just a lot of variation across nations in allocation systems and donation, and that provides a natural experiment. And some of my collaborators like Sumit Mohan at Columbia have really been drawing attention to this tremendous variation center to center and region to region within the country. And I think that variation offers some potential lessons that we can glean with epidemiology as well. So what I'm going to cover today is, for some reason my slides are advancing on their own, I'm going to try to prevent that, is first I'm just going to talk about this high and persistent US kidney discard rate. I'm going to talk a little bit about how we map the quality of discards and the quality of kidneys and the discard to certain metrics like the kidney donor profile index. Suggestive evidence that many discarded kidneys would benefit waitlisted patients. I want to focus on a really interesting controversial practice, which is the question of whether or not if you biopsy a kidney as part of the allocation and evaluation process, you learn more information than you already had. I want to think about what happens in the United States in terms of your prospects for transplant and your outcomes, depending on which center you go to. And my sense is in the United States, most people just go to the center that their nephrologist points to. Then we'll talk about, is there any way out of the kidney shortage and the key role of general nephrologists? So, big picture, I think the situation is probably very similar in Canada, but maybe without some of the same constraints that we look at in the United States, which is that certainly if you accept lower quality kidneys, even if you repair them, even if you try to regenerate them, you're probably going to have more DGF, more complications, longer hospitalizations, and higher costs. What I think is interesting is that you can probably measure the dollar signs, but I do think that there's a real emotional component here too, that people who spend a lot of time on the inpatient transplant service shoulder. So what they really feel is they can think of and relate to the feeling that they had when they walked into the room of a patient who is hopeful and is now despondent, because they're rejecting or dialysis has been going on. So there's emotional and dollar sign costs. In the US, our quality movement has really had a lot of good and unintended consequences. All the centers get report cards. Personally, I'm not quite sure that the patients look at them, but the payers definitely do. And then as we've tried to share wider in a vast country, there's also been greater burdens on the organ procurement organizations to try to disseminate information and be efficient. So there's barriers and potentially opportunities to overcome those barriers to using worse kidneys. So just a little bit of vocabulary for everyone, particularly those who don't work in the kidney transplant world. Over time, we've come to learn that there are many things about, many attributes of a donor that might affect the quality of their kidney. And in the past, we would just talk about these individual variables, and different people had different variables that they thought were more important. There was an attempt about 10 years ago to integrate them all into one score so that you're sort of applying the same ruler to all the kidneys. The goal was simplicity. The sort of source metric is the kidney donor risk index. And then to make it easier to use, they turned it into the kidney donor profile index. All you need to know is that it's a quality score with every single kidney that's offered in the United States. They tell you the score front and center on the screen. It's built right into allocation. They only give kidneys with good scores to children, for instance. I'm going to kind of use the terms interchangeably. But with the kidney donor profile index, it's 1 to 100%, lower is better, and they scale it to last year's donors. So as an example, if someone says, Joe, I got a kidney for you, KDPI is 38%, donors 40, that means this kidney is in the top 38% of all kidneys as far as we can tell. So what's interesting about these scores is that they really, really, really predict if the kidney is going to get used or not. I mean, it's very hard to get a model, with a C statistic, or, it's probably closer to an AUC, that's above 80. So people are really trained on this score. But its accuracy in predicting the survival of the allograft is much lower. It's like 0.6. So it's super interesting that you have a score where it definitely changes behavior, but doesn't necessarily reflect perhaps what people think that it reflects. So it's not a coin flip, it's better than that. And I one of my separate projects, without any results yet, but I think we'll have some soon, is to try to improve on the kidney donor profile index. Why is it so bad? We can speculate on a lot of reasons. Primary FSGS and other causes of ESRD are not in there. HLA matching is not in there. Age can mean a lot of different things. Of course, you can tell that, I'm in tremendous health despite my age, but, other people who are 50, are probably just, looking really old. So I'm joking. But anyway, you get the sense that, 50 is not 50 is not 50. And then, of course, the other thing is that allograft failure probably has a lot to do with things that you can't know until 12 hours have passed after the reperfusion event. Reperfusion injury is a diverse event. And then, of course, some allografts are lost because the patient dies. And sometimes patients die because their graft fails, and sometimes patients die because they got hit by a car. It's not like you could really know that just because you knew the donor well. So anyway, we have this mediocre metric, and not much work to get rid of it. So my opportunity, as Joe mentioned, was I was lucky enough to spend a year abroad, partnering with some scientists in France, like Dr. Lupi, who usually looks more cheerful than that. He's a great scientist, and one of the great things about these cross-border communications is that people in specific countries innovate in specific ways and forget about what other people are doing. There's a lot of cross-border skepticism that I think is unwarranted. So I'm just going to tell you how I perceived the French healthcare system after about 6 months. You may not be as ignorant of it as I was, but basically, my sense is it's a really good system, and this is a system that, on average, delivers better outcomes than the U.S. at a lower cost. The New York Times wrote a whole article about this with health economists, sort of reviewing each system and comparing them. That for the France versus U.S. comparison, they called it access versus innovation. Everyone there is eligible for a basic governmental health plan, but about 60% of the French have supplemental insurance from their work or their union or something like that. So there's public and private hospitals. So, I showed you this picture at the beginning. How do things look different to me? So I was at Necker Hospital, which, arguably did the first kidney transplant, a living donor kidney transplant. It lasted 3 weeks. It looks kind of like potentially a rundown municipal building in the United States. In the United States, our hospitals are, really big, and a lot of them are big and gleaming with, lots of windows. So things kind of look different. You sort of wonder whether or not people are putting their dollars in different places into, architecture versus healthcare. But I don't know. I'm just going to say that was one of the first things that sort of appeared to me to be different. But there's a lot of similarities. Obviously, these are people who've trained in great hospitals, often trained in our hospitals. They're using same induction immunosuppression, same maintenance immunosuppression. They've got long waiting times, and like the US, they have comprehensive national registry data, so they can count every transplant and every waitlist event. So what's different? smaller country, 60 million people. I'm told, much lighter burden of regulatory oversight. It's definitely less living kidney donation. They have not maximized their opportunities for parent exchange. They are not doing procurement biopsies to determine kidney quality. They're not doing as much of a wallet biopsy like they do in the United States to make sure that people can pay for their transplant. And also, I think it seemed to me that there was more physician autonomy, and their length of stay was much, much longer than, my hospital. In my hospital, a living donor recipient, might spend 3 days in the hospital, which is not very much time to, go through this transformative event, potentially with mental clouding by, discharge of uremic toxins as well as high steroid doses. So one of the first things we did is I tell this story where, I was rapidly relearning my mediocre high school French. And I would sit at rounds with all of these amazing people, Alex, Christophe Legendre, Olivier Aubert, and they would run the green sheet, and they started talking about donors who were 85 years old. Which I've just assumed until I heard it 2 or 3 times that I really didn't understand. There was so much I didn't understand. I thought maybe they were talking about the PRA, but no, they were accepting donors in their 80s, which I've never seen. And I just would be, I think what happens in the United States when there's a donor who's 80 is when they call the organ procurement organization, someone just hangs up the phone. So I realized very quickly that they were accepting donors that I've never seen accepted, and so I partnered with Olivier and Alex, and we got the registry data from the 2 countries, and so you remember that probability of discard figure I showed you earlier. That's the U.S. on the left, and the right is France. So they are accepting. They're much less likely to discard a kidney with a bad kidney donor risk index. So what we did here is we put together this cohort from 2004 to 2014. We looked at all the kidneys that were transplanted and all that were discarded. And the kidney donor risk index is again on the bottom. And if you've got the United States on the left and France on the right, and what you can see with those green lines is that the kidneys that they are accepting, have on average much worse scores. And what's really fascinating to me is that if you express it, this is just for the nephrologists in the room, as the kidney donor profile index, what you see is when you force this, when you take this score and you force it on the population of US kidneys, if you look at the bottom, 100 is the worst score you can get. That's a kidney that is going to be accepted by almost no centers in the United States. And if you're doing informed consent with your patient, you're going to have to say, that's a kidney that's worse than, is basically worse than 99% of the other kidneys that were offered. Look how high that band is in France. So essentially what you're seeing is that the French transplant kidneys that US centers almost never do. And our attempt to turn this risk index into something that goes from 0 to 100% leads you with a metric that completely fails to describe what the French are doing. Because what the French are doing is they're taking hundreds of kidneys that are the worst kidneys ever transplanted in the United States that we almost always throw in the garbage can, and they're putting them into their patients. So this was really striking. And, when we did this research, it was one of those things where we built a bunch of models, but the descriptive data, was 95% of what was valuable about the work. So what you see here is you see the North American donors and the French donors. And the main thing that stands out is that the French donors are 15 years older. And that is just a large number that no amount of, multivariable adjustment is going to make go away. That's the main thing that's driving their higher kidney donor risk index scores and KDPI scores. There's also more strokes. But what you're not seeing, and diabetes is about the same. Sex is about the same. What you're not seeing is you're not seeing a lot of hepatitis C because they don't have a lot of hepatitis C there, lucky them. And you're not seeing a lot of DCD. So the other thing that was just super interesting is to say, let's look at trends over time. So from 2004 to 2014, your waiting lists, my waiting lists getting bigger. waiting time getting longer, patients getting older. So in a sense, the natural response to that would be to accept older and older donors to put those kidneys into your older and older patients that you're meeting in clinic. And that's exactly what they did in France. So this is the age of the transplanted kidneys. It goes up, 10, 12 years. In the United States, it stays completely flat. So it looked to me, sort of superficially, that in France there was adaptation in the domain of age, whereas in the United States, we pretty much just stuck with the status quo in the age department. So then, we fit some models and we basically said, and this is Olivier who did so much, it was such a pleasure to partner with him. Basically what we did is we said, since we've shown that the kidney donor risk index predicts discard and transplant so well, let's pretend that the United States accepted kidneys just like the French do. What would happen? So as kind of a back of the envelope, you get the sense that this would be French acceptance patterns, that essentially the blue and the orange are the French acceptance patterns. In 2014, the number of kidneys transplanted in the United States would have gone up by about 1,800 or so, and the number of discarded kidneys would have gone down the same amount. So it would not have, it would not save our transplant system and transplant everybody. But, over 10 years, it would be a meaningful difference. And in order to then predict how many additional years of allograft survival you would achieve by doing this, we would basically have to look at what kinds of kidneys we would be using instead of the kidneys we're using now. And, a lot of them are these lower quality purple and red kidneys. And just to give you a sense of how long they would last, with death censored graft survival, it would be about, 80% 3-year survival. So with these gains in allograft life years, what this shows is that, because kidneys with the best quality scores are not discarded that much, using a French approach would not get you many more transplants from the 40-year-old that I talked about at the very beginning. Most of these transplants are going to come from older donors, and that's where most of the allograft survival is going to come from, with reduced kidney discard. So I guess one of the key things that I wanted to mention again is that this is not a story of the United States as some sort of innovative transplant backwater, or sort of non-innovative transplant backwater, and the French are futurists and doing everything great. There are many things that the French are not doing that they ought to do. They should try to increase their DCD. They should try to do more paired exchange. Fortunately, they didn't have an opiate crisis. So I was very excited to tell them about my hepatitis C transplant work and yours. But they think that's interesting. They didn't have an opiate crisis like we did. And so that's not really an issue for them. So that's not an innovation, but it is an example of how in North America, we innovated a lot, and there's plenty of things they can learn from us. There's certainly limitations here. You always worry that a discarded kidney with the same kidney quality score won't perform as well as an accepted organ. The best, I think, response to that is in the United States, they've done a fair amount of studies of kidneys from donors where one kidney was transplanted and it did well, and the other kidney was discarded. Now, is it possible that the discarded kidney had a torn vessel or a tumor in it? It is, but it just happens so much that you get the flavor that there are good kidneys going to waste. Also, the KDRI does not deal with transmissible diseases other than hepatitis C. And this initial analysis didn't address pathology, which we're going to get to next. And in the United States, about 50% of kidneys are biopsied as part of allocation, which is quite a lot of biopsies. So would these kidneys benefit anyone? And I'll just kind of touch lightly on this data and some of the things we've learned. So this is a well-known analysis by Alan Massey and Dory's group. It's probably been, cited a bajillion times. And what this is the cumulative mortality ratio. This is the years since transplant. And these are kidneys that are in the bottom, in the sort of tertile of 70 to 80%, 81 to 90%, 91 to 100%. These are the worst kidneys. And what you see here is it's just a reminder that transplant is an act of hope, and it is a good option for people who are dissatisfied with the status quo and willing to accept upfront risk for long-term benefit. So, almost every analysis will show you that at least in the first 3 months and potentially longer, out to a year and a half, your patient's risk of dying will be higher right in that peri-transplant period. Now, I've done some subsequent analyses with marginal structural modeling that would suggest that this cumulative mortality ratio is too high, but it's definitely above 1. So you buy upfront risk for long-term benefit. And what it looks like is that the older the donor or the worse quality the kidney, the longer it takes to achieve equal survival until you get to a point where on a population level, your survival is better. And, ultimately, there's a face validity to accepting older donors because, of course, our patients are getting older. I don't know what the exact trends are in Canada, but I wouldn't be surprised if it's similar. But, here you have some pretty substantial growth over 20 years in the percentage of our patients who are recipients or on the waiting list who are over 65. It's almost a quarter of our patients now. So the way I say it is that if you're in nephrology, and probably this is true of all of our fields increasingly, you are a geriatrician. And really the only question is whether or not you've accepted that subspecialty. And, it's definitely the case that the younger the recipient, the greater the gain in life expectancy. And, what you see here is this is the general population. These are patients on dialysis. This is their life expectancy, and this is the jump in life expectancy that they get if they get a transplant. So they don't usually jump back up to blue. They only jump up to green. And the older you get, once you get up to these patients in their 70s, that gain in life years is small. It might even be 0. However, there's also quality of life. So that's the sort of optimistic view that we ought to be using older kidneys for older donors. Like everything else, it's important to look at the totality of the data and remain skeptical of what you think you're seeing. Where I find skepticism is from the Eurotransplant Senior Program. And as I understand it, basically they preferentially allocate kidney from donors over 65, and France is not part of this program, to recipients over 65. They try to allocate locally to minimize cold ischemia. They don't do HLA matching. And all these elderly candidates are also eligible for regular kidney allocation. The US does not really do this preferential allocation. You have to opt in for the lowest quality kidneys. And so what you see here, this is a complicated figure, but I think if we look very closely at it, it'll make more sense. This is 1-year survival, and this is 5-year survival. And what you have here is you have graft loss, and I think the most important thing to look at is patient death. So if you take over here an elderly donor and an elderly recipient, by 5 years, 30% of those patients are going to be dead. And if that kidney is a DCD elderly kidney, then it's going to be 36%. And there's a lot of primary non-function in these groups. In the over 65 donors, they get 6% primary non-function. If they're DCD, it's 12%. So what's interesting, so here you really see in this area with their experience, with these patients who are over 65, looking at kidneys over 65, to me, they either need to be very dissatisfied with dialysis or looking for quality of life benefit. And so essentially what these authors said, looking at dialysis, as they said, versus transplant, as survival rates for these elderly patients on dialysis improve, there is no apparent survival benefit for transplanting these very elderly donors. And that, to me, is very interesting because it makes you recognize that you always need to look back at what your reference situation is. So I speculate that in the United States, maybe more aggressive kidney acceptance really makes sense, in particular because our dialysis outcomes are not very good. They really don't stand up to what they achieve in France and Northern Europe. And I hope that will change in the future, but for now, that makes transplant an ever more attractive option, perhaps more attractive than getting dialysis, versus transplant in the Eurotransplant region. So the next place we went is to say, let's look at kidney biopsies. And what's interesting to me is that there's many of us who believe that in the United States, at least the way that we perform kidney biopsies, it's essentially in the causal pathway to discard. And I think one of the things about it that's interesting is that as nephrologists or say hepatologists or whatever, we're used to thinking of biopsies as the gold standard information and really good information and important information. But I think what's difficult is that in our training, we're really used to a situation where we don't biopsy patients who come in for well visits or for, just average visits to their primary care doctor. We biopsy patients where we're confused and where we need more information. Someone is in an acute situation most of the time. The average kidney donor, many of them are people who had some stable comorbidities and, they died by suicide or they had a stroke. So to biopsy half the kidney donors is a little bit of an unusual situation compared to how we thought about biopsy, say, in renal fellowship training. So I think the field got stuck by asking themselves, do kidney biopsies have any association with allograft outcomes? And I think the issue is that's the wrong question. I completely believe that biopsies are associated with allograft outcomes, but that's not really what matters. What matters is if I take, someone at UHN and I show them all the basic data about that donor, I say, here's the trend in creatinine, the age, the comorbidities, and I want to predict allograft function. The question is, if I biopsy them, does it add anything on top of that? Because knowledge has to have incremental value for you to want to use it. So that was the way we asked that question. And I think it was, to me, the burden of proof, at least in contemporary practice, really lies on people who are defenders or advocates for biopsies because they may promote discard, because the biopsies may be low quality. They're often read under time pressure. So, the proverbial situation in the state of Pennsylvania where I live is, it might be a small hospital in a rural area. And then the patient, is transferred maybe to a regional trauma hospital. Someone does a biopsy. The biopsy is read by some pathologist who might not have any renal pathology training in the middle of the night. And then that process adds cost, cold ischemia time, sometimes occasionally a fistula, very, very occasionally, even a page kidney. I mean, these are rare, but they happen. But they also add complexity to allocation. So just to give you some other interesting data, because a lot of this work's really been driven by Sumit and Ali Hussein and his group at Columbia. There have been some situations where what they do at Columbia, for instance, is that there's a biopsy done through allocation by the organ procurement organization. Then when the kidney shows up at a place like Columbia, they may biopsy it again on the back table. So there's an opportunity to compare the biopsy done when they were trying to decide who gets the kidney and does anyone want it versus a biopsy done at a really good center, read by really good pathologists, which you'd consider sort of the gold standard biopsy. And essentially what you see is there's a decent amount of disagreement. For instance, here, if we look at glomerulosclerosis, one biopsy is read as optimal. The reperfusion biopsy, which is meant to be the better one, read as suboptimal 30% of the time. So you get a fair amount of discordance in the biopsy and the rush biopsy versus the gold standard biopsy comparison. And of course, it can happen in any compartment. And of course, you never really know what the accepting team is focused on, which compartment. So there's this international variation in practice. So what happens in France and Belgium, and also as I understand it at Toronto, is that when they're offered a kidney, there's no biopsy information. But after they've accepted the kidney, not knowing anything about renal pathology, they biopsy the kidney on the back table. Then they send that biopsy to their renal pathologists who are under no time pressure. It's just used for future clinical care, so it might not be back for 2 weeks. So what we said is, let's look at the French and Belgium cohorts, and let's do a predictive model to predict allograft survival. And then let's see if we add biopsy on top of it, does the prediction get any better? And then the second one we did, which was fun and a little more speculative, is we said, in the United States, we know when a kidney is discarded. We also know when the Organ Procurement Organization mentions that the leading reason for discard was biopsy. So let's look at all of these kidneys discarded for bad tissue, not for having HIV, not for having fungemia, for bad tissue. And let's see if we can find any similar kidneys to those biopsied kidneys that were transplanted in France. So here's the cohort. What we did is we did a development cohort with the French center, validation cohort with the Belgian center. And to build our initial models, we used donor characteristics and recipient characteristics, including pre-transplant DSA. And then we followed forward these cohorts of patients. So here are the development and validation cohorts. And again, what you see is pretty consistent with what you saw before. A lot of these donors are older than donors we use in the United States, and a lot of them died from a stroke. That's very common. About a quarter would meet our old expanded criteria donor criteria. And if you look at glomerular sclerosis, one thing that you see is that the Belgian cohort, their pathology was a bit better than the French cohort. Maybe 5% had a high score for IFTA. There was some arterial sclerosis for sure. And then in the univariate analysis, the things that came through is in the univariate analysis, all of these pathological findings are significant if you look at them one by one. But if you do a multivariable analysis, ultimately, if you just have KDRI, prior kidney transplant, and DSA, only IFTA remains statistically significant, but it doesn't add anything to your prediction. So here I just want to pause for a moment, because this is something that it took me a few years of epidemiology training to recognize for myself, which is that just because there's a variable in the model that's statistically significant, that doesn't mean that it adds anything to prediction. There are some models that are explanatory, some models that are predictive. Prediction is about seeing the future. It's not about trying to understand biological relationships. So if you want to see the future, arguably, if you have the KDRI and a couple of recipient characteristics, you are not going to predict allograft failure anymore if you add biopsy to the results. And that's what these curves show. So the incremental predictive accuracy that you get from biopsy, very low. We did the same thing with the Belgian cohort. It was smaller. Directionally, you find the same things. Biopsies seem to be, worse biopsy potentially associated with worse outcomes, but not statistically significant, and very little incremental gains. And again, as I mentioned at the beginning, the accuracy of all these models, remains quite modest. It's hard to predict with great accuracy how your kidney transplant recipient is going to do. So we started with that conclusion, and we said, we just don't think that right now, if the burden of, if you buy my argument that the burden of proof is on those defending biopsies and allocation, there's not a lot of evidence here that you get a lot more predictive accuracy. So this is some work done by my mentee and colleague Vishnu Patluri. He did some very advanced multivariable matching techniques that were pioneered by a Wharton professor at Penn. And what we did is we said, let's take kidneys that were discarded in the United States due to biopsy. Let's see if we can find any kidneys at these French centers that really looked a lot like these discarded kidneys that were discarded because of biopsies. So we matched on the kidney pathology, and we also matched on age, and then secondarily we matched on the kidney donor risk index. And what you can see here, just briefly, these are the discarded kidneys. Exactly as you expect, they have a lot more glomerular sclerosis than the transplanted kidneys in the United States. No surprise there. And when you look at the transplanted kidneys versus the North American discarded kidneys, the kidneys that are discarded in the United States are older than French transplanted kidneys, and they have worse features. There's a lot more diabetes, for instance. So what we found is that we could match almost half of the discarded US kidneys to French transplanted kidneys. And that to me makes perfect sense. I just don't believe that the French would transplant any old kidney that we happen to have in the United States. but it looked like they would transplant about half of them. So what this is these are figures that show you how good Vishnu's match was. This is basically every transplanted kidney in France, every discarded kidney in the United States. They look real different in terms of pathology in the KDRI. But after the match for those 493 kidneys, 493 in the garbage in the United States, 493 transplanted in France, they look really similar. Take a look. This is the overlapping KDRI, and this is like really tight matching on glomerulosclerosis, IFTA, and the CV score, which is the pathology score. So they look really similar. And what you find, if you look at those kidneys that the French transplanted, the ones that look so similar to discarded United States kidneys, they basically look like unselected ECD kidneys in France. So they don't look like standard criteria donor kidneys that were transplanted in France in terms of survival. They look a lot like unselected ECD kidneys. So you get a sense that, again, that there are potentially some lost opportunities in the United States. And that if I could take a drone and I could fly some of these kidneys that the United States doesn't want up to Canada, perhaps, or over to France, some of them might get transplanted. So, the other natural variation story is, in the United States, and Sumit Mohan led this work. I've collaborated with him a little bit. But even before I get to that, I wanted to talk about another piece of work that I did with another assistant professor at Penn, amazing researcher, super quantitative, just brilliant person, Jordy Cohen. So what we did is we said, let's just look descriptively first at what happens to waitlisted US patients who refuse their first offer. So if you look at those patients who refuse their first offer, or the center did, less than half ever get a transplant, but 43% did get a transplant. So let's focus on these 43%, because a critic might say, Reese, I don't really care about patients who refuse their first offer because some were probably too sick to ever get a transplant. So let's look at the 43% who did get a transplant. Half of them got a transplant that was the same quality or lower than their first offer. And that's what you see over here, basically. These are the 41,000 patients who they turned down the first offer. They got transplanted with a second deceased donor offer. A lot of them accepted a kidney with a 10% lower score. A lot of them accepted a kidney with a score within 10% of quality. And really only a minority accepted a kidney that was much better. So anyway, it's just interesting. You get the sense that a lot of times if you turn down a kidney hoping a better one will come in the future, that's not what happens. So what Sumit's group did is they said, let's look at, there were some modest modifications to the kidney allocation system in 2014 in the United States. The primary thing was, particularly for the lower quality kidneys, they said you have to share them wider. There were a lot of goals to this change in allocation, but one of the aspirations was we'll reduce discard. So the goal of this group was to see whether or not how big the center level difference is in the probability of transplant, but also how big these center level differences are right in the same geographic areas, and did it change pre and post this shift in allocation. For convenience, all the outcomes are basically 3-year transplantation probability. And essentially what you see is that in the earlier cohort versus after the change, CAS is the new kidney allocation system, the rate of deceased donor transplants over 3 years went up modestly. Living donor transplant didn't change, death barely changed. A slightly larger group were removed from the waiting list, and a slightly smaller group remained on the waiting list. But this is your scenario. Basically, if you're on the waiting list for 3 years in the United States, about a third of you get a transplant and 22% get deceased donor. That's the big picture. So this is the variation in the 3-year transplant rate at centers across the United States. So it just varies so much. And again, the focus here is deceased donor transplant. So tremendous variation, some of it geographic, of course. We know that until the most recent change in the kidney allocation system, that there was so much geographic variation in people entering the waiting list and donor organs. So this is within the allocation regions. This is mine. And again, you're looking at this 3-year probability of transplant. In some of these regions, the variation is just massive. Each one of these is a center. So I think what Sumit was showing here is that even right in the same region, it might matter a lot which transplant center you go to in terms of how long it takes you to get a transplant. And in the United States, the healthcare system is, very laissez-faire, kind of willy-nilly. So you have these crazy situations like in Boston, which I'm sure Catherine remembers well, where you can look at the window of the Brigham and Women's Hospital right across the street at the Beth Israel Hospital, and they've got all this duplicative services, transplant centers doing the exact same thing. So you can open a transplant center. So in, Boston or Philly, you got tons of choices, but which center you choose, it might really have a big effect on your transplant probability. And this is a little bit of a busy slide, but if you ask, what was driving transplant probability, it did have a lot to do with organ availability and, how many high KDPI organs you accepted. A lot of other things like percent listed inactive, much weaker relationships. So a crazy story from my area. Many of the transplant centers in my area, including my own, are quite conservative. So if you looked about a year ago at what happened to kidneys from deceased donors in my area, from our OPO, which is very effective and very aggressive, there were 451 kidney donors, 900 kidneys recovered. Where did they go? So the busiest transplant center in my region was mine. The second busiest was Miami. The second biggest transplant center in Philadelphia was in Miami. Now, how is this possible? What it means is that many, many kidneys were offered to all these centers and they all said no. So our organ procurement organization called Miami, which is currently the busiest transplant center in the United States, super aggressive. And they would say, look, I know that this proverbial 72-year-old kidney is not going to get taken by anyone. Would you like it? They fly it down there. So there are these kind of wild situations where one really aggressive transplant center will take kidneys that are turned down for, 5,000 patients in one region. And this is what I'm just showing again, that big dot down there is Miami sucking up kidneys. So what can we do about all of these problems? And I'll cover this briefly, but I just want to talk a little bit about what I talked about at the beginning, which is the emotional burden and how your brain works. So I think, hard to prove, that there's something called the availability heuristic, which is a reason why in many US centers they turn down kidneys, because many transplant people are not in the dialysis unit very much. So what they emotionally deal with is they deal with the patient with a transplant that didn't work out that well. It's a story that sticks in their brain. So it turns out if I ask you, Atul or Joe, do you think people in Toronto who ride bicycles get in bike accidents very much? If you saw a bike accident last week, you're going to say, oh yeah, it's very likely for that to happen. But if you never see people on bicycles get hit by cars, you're probably going to say, if it's not available in your mind, that image, you're going to say, I don't think so. It just doesn't happen very much. People are not very good at probabilities. So the transplant staff can easily recall stories of transplants gone wrong. And the people in dialysis units can easily recall a story of people dying in the dialysis unit. So the people who are accepting the kidneys don't have as available in their minds stories of bad outcomes on the waiting list. So I think that that's a part of it. And another cognitive deficit that we have is that we're more afraid than we're more afraid of sins of commission than omission. So it feels worse to accept a kidney, feel like I put this kidney in a patient and the patient does badly, than it does to turn down kidneys. If your patient on dialysis dies and you're in a transplant center, you might feel like, well, I didn't do anything wrong. Dialysis killed that patient. It wasn't my failure to take kidneys. So what could we do? So what we could do is we could change allocation and we could say, all right, this is how it's going to go. I've got all your data, Transplant Center X. I know if you ever take low quality kidneys, and if you never take low quality kidneys, I'm never giving you any. But Center Y, you take high quality kidneys, I'm just going to change allocation and send more kidneys to your patients at the top of the list. So I guess the big equity issue would be, are patients who are going to the less aggressive centers then disadvantaged? You'd have to hope that they knew that their center was being disadvantaged in allocation and still chosen to go to that center. You could pay centers more. You could throw dollars at the problem. You could, and maybe that would be reasonable. If you've got a socked in DGF, that's costly to deal with. You could also take advantage of the fact that we're all like really competitive people. That's how we got to be doctors. And you could say, okay, I want to motivate this center. What I'm going to motivate them with is we're going to give an official blue ribbon designation to aggressive centers. And I'm telling you, in the United States, they would be very proud to have those blue ribbons and market them and feel good about themselves. So it wouldn't really cost you anything, but you would take advantage of people's competitive natures. I talked about fast tracking. I also talked about dual kidney transplants. And then you could change the center report card in the United States, and they did do this. They basically changed the threshold with which a center would get a bad report card, and we'll have to see what happens with that. We don't know yet because this center report cards are kind of on hold because of the pandemic. And then I think general nephrologists play a huge role here. And I think a piece of it is helping patients to understand in a continuous way that all the options unfortunately involve risk. And then I think that the other place that the general nephrologists play a really instrumental role is helping centers to know how the risk tolerance of their patients evolves. Because, you know, my experience has been that sometimes patients are, say, on PD and they're doing well, and they might not really want to change the status quo. But then they get some peritonitis, and maybe they have a heart attack, but they recover. Now they're doing in-center dialysis. They had to leave their job, and they're very unhappy. And so now you might have a different conversation with them. So that the patient's tolerance for dialysis or dislike of it, their willingness to take a risk and take that leap can change. And the general nephrologist would be a lot better at knowing that. One conversation that Sumit and I have also had is this question of whether or not there are ways to keep transplant centers honest. Maybe patients and referring nephrologists should be periodically given access to information about how many kidneys were turned down for their patients. Maybe in the US, if we did that, nephrologists would refer less patients to Penn and, you know, tell them to go down to Miami. And of course, you know, we have to get really good at managing DGF. So anyway, that's the end of my talk. And I just wanted to thank my many collaborators. These are the folks in France who helped a lot. You know, Vishnu Patluri is on a great trajectory. You'll be hearing a lot more about Jordy Cohen in the future. She's really a brilliant person. And of course, I want to thank all of you very much for the invitation.
Thank you, Peter. It's quite a tour de force, very, very scholarly and very, very insightful. Thank you so much. I will field any questions that people have for Peter. Maybe as the chair, I will take the prerogative of asking the first question. Peter, your discussions around donor quality and the measurement thereof using indices and so forth, like the KDPI or KDRI, you know, highlighted sort of some of its some deficiencies, although understanding there is a need to in some way measure donor quality. And unfortunately, it also sort of tracks with certain behaviors as well. What's your thoughts around sort of whether we should be then also characterizing recipient risk, and how do we integrate those, or should we integrate the information across donor and recipient in a way that allows us to inform allocation?
Right. So, you know, it's a little surprising to me how primitive the KDRI is. I mean, it's really cross-sectional. So I have a grant, and I don't know if it's going to work at all. But what we're taking advantage of is we want to develop better kidney and liver risk scores. And you know, what the OPOs have, including, you know, Darren over at Trillium, is they've got longitudinal donor data from the hospitalization. That's one. Two is there are a lot of advanced modeling techniques which haven't been applied. Three is, you know, we have every reason to believe that, you know, interactions between the donor and recipient should allow us on some level to, you know, improve the prediction, you know, on a personalized level. I have a feeling that we're never gonna, at least in the next 10 years, get to extremely accurate risk prediction. But because we're dealing with such low risk prediction, I feel like there's gotta be room to maneuver here. And, you know, it's also, I think there's just tons of cognitive biases holding us back here. Just to give you an example, there's a well-known bias that has been described, say, among Uber drivers. So maybe an Uber driver drives every night. And by the way, I have all sympathy for Uber drivers. That is hard work. It's much harder than I do. But they might say to themselves, my goal is I make $100 every time I drive. Now, if you're driving on New Year's Eve, you can make that in 3 hours and stop. But that arguably would be exactly the wrong decision, because that's a night when you're making $33 an hour. You should drive until 4 in the morning. But I think we do this sort of thing. And I think at my center, what happens sometimes for capacity reasons is we did 4 transplants. So when the 5th offer comes, we say no, because we're feeling good about this week. So I think that there are ways, if you had some supervision and feedback over the decision-making process, that I think things would change a little bit. And so you could have better models. You could also have better decision support, and that could be human or it could be, non-human.
Yeah. No, thank you. And I echo that. I think this whole idea of using decision tools and aids as the end all and be all is highly problematic. Ultimately becomes a component of that decision process. So the question is, how do we focus on an overarching structure on decision making that incorporates tools and other indices, but then really sort of integrates all the other sort of kind of intangibles and things in a way that's sort of reproducible and at least transparent. Very good. Atul.
Yeah, thank you, Joe. Thanks, Peter. I really enjoyed your talk. So my question was around like this KDPI, and does it, do these risk factors that are incorporated into the KDPI evolve over time? Because, I notice, and maybe you could comment on the Hep C piece, and how much weight that carries in the donor KDPI, and whether that's changed now that our Hep C treatments have evolved so dramatically over the last few years.
I mean, I totally agree. Every single person who has been involved in, transplantation of hepatitis C viremic organs, including all of you, is completely shocked by the fact that that'll add 20 points to your KDPI score. It just can't be that big of a penalty to be accurate. And I'm guessing they're going to refit the models. Now, the models are based on allograft survival. The reason that we feel like it's certain that these models are going to be refit in the future is that, we did the same sort of very accurate matching where we took recipients of hepatitis C kidneys, we compared them to recipients of non-Hep C kidneys with the exact same allocation score, and then we matched them to another set with an allocation score that was even better because we took out the hepatitis C from the calculation. And what we found is that the 1-year creatinines looked a lot like the recalculated KDPI scores, and they looked better than the comparators with the same allocation score. So plain English, if you get an offer of a hepatitis C kidney with a KDPI of 40, and the exact same moment you get an offer of a kidney without hepatitis C with a KDPI of 40, take that hepatitis C kidney because it's probably better than it looks. So to your point, these models need to be refit. It's a slow process, maybe too slow.
Okay, thanks.
Just to highlight that point as well is to models that were established on data in the past that then change behavior subsequently because it's applied as a policy, the model tends to degrade over time in terms of its performance, just by the fact that we're using it for decision making. And so, as Peter said, it's actually incumbent on the modelers to ensure that it's done again and refit for the more current data to ensure that decisions are continuing to be made in a more appropriate way versus not. So, and there's actually a whole field of prediction modeling around this.
Makes sense.
Yeah, Jed Gross has a question. He's our bioethicist here. Peter says, thanks for this talk. Really intriguing use of comparative data. From your collaboration with French colleagues, do you observe any national differences in how the ethical/fairness aspects of organ offers are handled? So, for example, the role of patient choice throughout the process. What happens if a recipient experiences primary graft function?
I think that's a fantastic question. So I have a very big limitation, which is that when I'm in France, I think I understand about 85% of what they say. But once they start talking really fast, or once they start using idioms, and when they talk to patients, we use a lot of idioms and colloquialisms, I'm like really lost. And they'll talk for like 15 minutes and then they'll lean over to me and they'll be like, Peter, I said this and that. And they'll just say 2 sentences. And obviously I missed the whole thing. My sense is in the United States, at the risk of sticking my foot in my mouth, that there's a growing emphasis on shared decision making, bringing the patient into the discussion. I didn't hear as much about that in France, and so it may be that movement is stronger in the United States in terms of talking about risk, and that can sometimes backfire. Like right now, we find that about half of our patients won't opt in for a Hep C kidney. Sometimes I worry that a little maternalism could help, but we spend a lot of time talking about risk and what do you want, and I feel like sometimes we look at the patient, we're like, what do you want, and they're looking at us and they're saying, what would you do for your mom? And so striking the right balance of informed consent and giving patients guidance who want it, I think that's the master clinician, and we struggle with it.
Any other questions for Dr. Reese? There's a little comment here by our medical director of lung, or now the division head of respirology and lung transplant here. It's a great talk, even for a non-kidney person. Dr. Singer.
So I think Blaine and Catherine have questions.
Oh, great. I can't see them. So Blaine, please go ahead.
Oh.
Or Catherine, whoever's.
No, Anna first, then Blaine, then me.
Okay, thank you.
Anna, sorry.
So sorry, I can't find my hand, my other hand. That was a great talk, Peter. I was curious, again, along the same line of discussion about prediction, in addition to adding sort of recipient bit of the story and clinical information that's of relevance to the recipient, do you think that addition of sort of more precision-based molecular profiling would improve your predictions, and how do you see that fitting in the future?
I love that question. I'm really, really interested in that. And, basically, this trajectory I think that we're all on, we just don't know the speed, which is, better prediction. Probably molecular prediction comes in there, particularly when it's, can be done rapidly. And then organ repair, and then organ engineering and making organs. And all of those things are happening. I think it's just a question of integrating it, into the process quickly. But I would love to see molecular prediction get built into the process, particularly if it could be done in an automated way. It's possible even that biopsies would help us, but the way that we do biopsies in the United States on half the kidneys and in a big hurry, maybe it's not so much biopsies are bad, but the way we do biopsies are bad. Mm-hmm. So I think that's a great thought.
Was Blaine still have a question?
Yeah, great. Thanks, Peter. I enjoyed the talk very much. Question for you on the flip side is, there's a reputation, certainly in the US and other places as well, where transplant centers go through boom and bust cycles, where you have someone who, someone comes in as a division director who's very gung-ho about transplanting organs, and all of a sudden you see usage rates and acceptance rates really spike. And then when you see outcomes data 2, 3, 4 years later, then they lose their job and they're on to another center, and the volume drops and it repeats it somewhere else in the locale. And so when you see numbers like Miami, for instance, accepting the most kidneys or second most kidneys from Pennsylvania, is there a better way that we have, rather than kind of, retrospective reporting, because obviously real patients are hurt in that, in kind of assessing what's the sweet spot, who is doing something they shouldn't be, and how do you find that balance rather than waiting until 2, 3 years down the line and understanding that we were clearly being too aggressive, the center was being too aggressive, and that the law of averages was just going to catch up there.
Yeah. So so I did I have a great mentee, Liza Sonnenberg. She's going to be at the University of Michigan. We did a study of kidney volume and 3-year outcomes, and we really beat up these data every which way. In the United States, there is no relationship between kidney volume and outcomes. And after a while, I really came to believe the data. Now, when you present those data, nobody likes them. It's counterintuitive. You get 2 main responses. The first is unmeasured confounding. Look, I'm a great center. I'm the University of Pennsylvania. You have no idea how hard I have it. I take kidneys that are really tough. Your data doesn't reflect it. That's one. They insist they're better. The second is that we have these guardrails. And so the minute that a center gets big and has any sort of problems, they bump them back towards the middle of the road. So I think the system is set up to keep people in a narrow band, and people fly outside the band, they get knocked back in. The other thing to me is that I think there's a huge patient preference issue here. So your outcomes might be bad, but I'm worse than average, but I'm not always sure that's a problem, because I think transplant the way it is right now, particularly for an older patient, it's an act of faith and it's a leap. If you're happy with the status quo, a KDPI kidney from an older diabetic donor is not the right decision for you. But we meet these patients who are like, Jesus, doc, I was on dialysis, person 2 chairs down from me had a heart attack and died. I saw them take my friend out on a stretcher. So get me out of here. And I think those are 2 different patients. And so I guess my My excuse for the large volume center that transplanted a lot of patients with bad outcomes is that I really hope some of those bad outcomes were in people who were determined to get out of their situation.
Yeah, very good. We're a little over time, but Catherine, do you have a short question?
Yeah, it's reasonably short. I'm institutionally obligated to ask an HLA question. Thanks so much, Peter, for your talk. And you put HLA on at least one of your slides, so you opened the door. As we think about, models that include both donor and recipient factors, HLA, at least for me, is one of the obvious ones. Maybe more important if you're 50 and getting a transplant than 85, because it takes some time to have those adverse outcomes. But what I really sort of reflecting on is where we are able to identify the mismatches or the matches between donors and recipients that lead to good or bad outcomes. We're really looking at studies of, if we're lucky, a couple hundred patients. The HLA data is extremely precise. It's methods to very high resolution. And those aren't the data that are available. The large registries have a lot of mis-HLA data, very, very non-resolved data. The learning of those very precisely running very, very unique, usually subscribed population, and actually then look what we have in register, try to integrate with some of these large scores, recognizing those data are far more crude. How does that work, sort of mathematically?
I didn't hear everything that you said, but I think I got the gist of it. I think the first point is that I am in complete agreement that I think better resolved HLA data, high granularity HLA data, is a lost opportunity in these models to predict outcomes. My sense is that, to your point, that it might be really, really useful. It might be less useful in predicting PNF and more useful in predicting longer term outcomes. And then the third point I'd make, sort of following on what Atul said, is that I think that's another example of data where it will probably help and it will probably need to get updated because, I'm hoping that we're going to get better humoral therapies in our lifetime. So I think it could add value in prediction, and then it will probably have to be rescaled over the next 10 years as our therapeutics improve. Because for me, when we have a patient with a positive DSA, we're just flying in the dark. The therapies that in terms of the therapies, not what we see, but those therapies too are, it's almost like an orphan disease. Small trials, we're not even sure how much plasmapheresis and IVIG to give, et cetera, et cetera. So I totally agree. I think it's great. And the study that we have a grant to do probably isn't going to be able to make any progress on that front because it is low resolution data.
Great. Well, my thanks to everyone for sticking around for 5 minutes extra, but in particular, thank you, Peter, for an outstanding talk. And you can see with all the questions, a really, really engaged group here. Really enjoyed your presentation. So thanks again. And thank you, everyone. Have a good day. And
thank you for the welcome.
See you again soon. Yeah, thanks. Cheers.
Thank you, Peter.